Before we begin, a quick disclosure. This podcast is sponsored by Innovative Hematology Incorporated, a leader in blood disorder care, education, and clinical research. Innovative Hematology may have direct or indirect financial relationships with some of the organizations, products, or companies discussed. Full disclosure and details can be found in the episode show notes. Welcome to We Bleed Too, where women's health meets real talk, real care, and real expertise. Hello, everyone, and welcome to We Bleed Too. My name is Magdalena Lewandowska, and I'm joined by Hilary Gaudreau and Janey VanLiew.
The unique thing about our podcast is that we have different perspectives from a hematologist, an obstetrician, and from a registered nurse. Pregnancy's impact on the body can't be understated. That's why planning for pregnancy is crucial and speaking with your healthcare professionals. For patients that are planning to get pregnant and have a blood disorder, what should they maybe do? What should they expect?
We recommend that any individual with a blood disorder or bleeding disorder specifically who is pregnant or is contemplating pregnancy really have a discussion with their hematologist about what that entails. Because there's a lot of things that can impact, the planning for such a pregnancy. There are certain bleeding disorders, for example, that make it difficult to sustain a pregnancy. There are certain fibrinogen deficiencies. For factor 13 deficiency, there's a pretty rare condition called plasminogen activator inhibitor type 1. There's no quiz on this deficiency. And those conditions basically make it more difficult for the implanted embryo to kind of survive and to be delivered full term. So there's different things we can do to replace those factors during the pregnancy or to stabilize the pregnancy in order to reduce the risk of like a bad outcome. That being said, it's really important for the individual to meet with genetic counseling to talk about, what are the chances of having a baby who's impacted with the bleeding disorder and how will this impact the delivery, and things that we need to think about are what kind of anesthesia are we going to use, right? Like, do you want spinal anesthesia, what we call neuraxial, which means like the numbing medication that's usually injected into the spinal area in order to reduce the pain that's experienced with delivery. And Dr. Gaudreau can talk to us a little bit about that. And, we want to know about what is the risk of bleeding after you deliver, both immediately, which we call primary postpartum hemorrhage, and then secondary, which is kind of later after the initial birthing period. And those things are really important to consider because we want to reduce the risk of any adverse outcome. And then there's certain conditions that can still increase your risk of clotting. So then we have to take that into consideration. So there's a lot of planning. And so we focus on the safety of the person who's pregnant or thinking about becoming pregnant, and then also of the baby. So usually the way we approach it here is we actually have the whole team involved. We have a multidisciplinary approach, and we have nurses whose job it is to help coordinate the delivery. And we have written plans for patients that describe all the details. Do they need to deliver here? Meaning, so we can round on them physically at the hospital where we have privileges as hematologists. Is it okay to deliver locally? Because some bleeding disorders are fairly mild and the levels can improve during pregnancy, like in von Willebrand disease. Or it may be okay for some women to deliver at their local hospital and with close monitoring and with a plan that's in place beforehand. And especially depending where you live, there are some rural areas and it just may not be feasible to get to a larger facility in time for delivery. So we need to have multiple plans and backup plans in place in order to ensure the safety of mom and baby. And then once the baby's born, we have to think about the type of delivery that we have. For example, we don't recommend the use of what we call instrumentation. So things like, forceps or vacuum on the head. Because of risk of intracranial hemorrhage for a potentially affected baby. So all of those things need to be considered, as well as, how do we reduce the risk of secondary postpartum hemorrhage? So, after delivery, we tend to use more tranexamic acid, which is a medication that reduces premature clot breakdown. And that's taken by mouth 3 times a day by the mom. So there's a lot of considerations that we have. And really, in order for us to bring everybody on board, meaning the nurses, the pharmacy, sometimes that means the coagulation lab, if we're monitoring particular levels during the time of delivery. We want the obstetrician to be comfortable with the plan, right? So if the patient goes into labor spontaneously, her ducks are in a row, we want the anesthesiologist to be comfortable as well, right? Because You can write one thing in your letter, but if the anesthesiologist comes in and says, I'm not doing that epidural, I mean, that's just, that's where the buck stops. Making sure that you have buy-in from everyone and doing things as safely as possible, I think is the goal.
Well, let's kind of start from the beginning. So we talked earlier about people who are iron deficient, and the pregnancy puts an extra demand on the body. So generally when a woman finds out they're pregnant or when they're planning to become pregnant, they take like a prenatal vitamin. Many times those include irons. Discuss a little bit about the importance of, again, having iron, especially during times of pregnancy.
Yeah, totally. About 1 in 5 pregnant women are iron deficient. And can become anemic. And it becomes a little more difficult to monitor anemia during pregnancy because there's natural increase in like volume that's absorbed into the body, which means that the blood becomes more dilute. So like, as opposed to, we talked about how 13 is kind of like a cutoff for anemia in the general population, which we hope that becomes a standard. 11 is what we use during pregnancy, what's an acceptable hemoglobin. Now, for people with bleeding disorders specifically, MASAC, the Medical and Scientific Advisory Council, does recommend checking a level once in the first trimester to screen for iron deficiency anemia, and then again in the third trimester if possible. And the reason for the screening initially is because, for people with bleeding disorders, there's a higher risk of iron deficiency anemia just because of increased bleeding risk in general and the likelihood of them having had heavy menstrual bleeding. So we want to correct that, if at all possible. And in the first trimester, we try not to give IV iron just because it hasn't been as well studied in terms of the effect on the potential pregnancy. So when we give IV iron, we try to save it for the second or third trimester of pregnancy. And then we repeat it. I mean, unless there's a reason to repeat it sooner. Like if someone's severely iron deficient in the first trimester and I'm starting oral iron, I'm going to repeat those levels more frequently just to make sure that what I'm doing is making a difference and making sure there's no need for things like blood transfusion. But then, in the second and third trimester, we want to make sure that as the baby's growing, there's a higher demand. So the way what I tell my patients is the body's really stealing so many of your nutrients from you, right? So iron, B12, folate. Now, folate isn't everything, right? It's our flour supplemented by it. It's in all prenatals. And in fact, if women can't take prenatals, like sometimes the only thing is they can take is the folate, right? And like some obstetricians, I think. I learned from Dr. Gaudreau recommend that if they can't take the prenatal. But oftentimes, as we talked about absorption, many people don't absorb it well enough. And by the time you're getting into your third trimester, the chances of you making a meaningful recovery with oral iron, if you have severe iron deficiency anemia, is really small. And then we worry about delivery, right? Because there's a risk of blood loss with delivery. So in those situations, that's the time you really want to medically optimize your patients. And you want that ferritin over 50. You want that anemia corrected to the best of your ability.
So women that are going to the store and they're picking up a prenatal vitamin, and especially for those that have a blood disorder, anything that they should look out for in a prenatal vitamin?
Yeah. One thing which we talk about, and Dr. Gaudreau, I think, has a good story to share about that, is sometimes there are supplements that get put into prenatal vitamins or other supplements in general that can increase the risk of bleeding. Do you want to share your story?
Sure. I'd love to. So we know that a supplement called DHA, it's abbreviated DHA, stands for docosahexaenoic acid. That's why we call it DHA. That particular fatty acid was shown to improve the overall outcome of pregnancies in women in maternal health. And it was also shown to have some benefits to the fetal developing brain, primarily during breastfeeding, because these fatty acid chains transfer easily to maternal milk. But we know that they also transfer through the placenta primarily in the third trimester. So when that data started coming out and became a bit more mainstream, approximately 16 to 18 years ago, all the prenatal vitamin manufacturers started jumping on this bandwagon and started including DHA in their prenatal vitamins. And in the beginning, it was a big deal and it was really heavily marketed and it was kind of advertised on the bottle itself. And then as time went on, it was, incorporated into all of the over-the-counter prenatals, a lot of them, not all of them. And then the kind of splashy front cover stopped existing. It just became a bit more commonplace. So Interestingly, the story that Dr. Lewandowska is referring to, when I was practicing obstetrics, I was taking care of a patient who was having her second child. Her first child was delivered several years earlier in another state, no complications with her delivery. With this particular delivery, her entire pregnancy had been uncomplicated. Her delivery was beautiful, and it was just one of those really lovely, uncomplicated, just smooth deliveries. No reason for her to have increased bleeding after delivery. There was no tear. There was no trauma. So after her beautifully uncomplicated delivery, I'm getting ready to leave the delivery room, and the nurse calls me back and said she's having a little more bleeding than I think is normal. And I'll just fast forward to 2 hours later. We had gone through everything on the list at the time that we had to try to get her bleeding to stop, to try to figure out why she was even having this bleeding in the first place. And eventually it stopped, slowed down and stopped, but we never came up with a reason why. So for her subsequent pregnancy, we kept that in mind, that she'd had this episode of immediate postpartum hemorrhage. And she ended up being delivered by a partner of mine. And when the very same thing happened with her delivery and he was involved, we both had the same story, basically beautiful delivery, uncomplicated. Why? So I decided to send this patient to the lovely and brilliant Dr. Ann Greist. And what I learned was that Dr. Greist asked the right questions. And as it turned out, this patient was taking a prenatal vitamin with her first pregnancy that did not contain this omega fatty acid, the DHA. But then in our efforts as moms to do the right thing, the best thing, the thing that we hear is best for our children, she switched and was taking the fancier prenatal vitamin that contained DHA for the entirety of her second pregnancy and her third pregnancy. And spoiler alert, it had unmasked her previously undiagnosed von Willebrand type 2 disease. And Dr. Greist had figured out that puzzle. So when I talk to patients with known bleeding disorders, I always stress, please look at the prenatal vitamin you're taking. Make sure it does not contain DHA or docosahexaenoic acid. At one of the recent clinical meetings, one of the speakers mentioned something that seems so obvious, and yet it wasn't obvious to me. And I touched on this earlier. Sometimes as moms, we'll do whatever it takes, no matter how painful, no matter how uncomfortable. If we know it's good for our baby, we might not do it if it's just good for us. But if we know it translates into fetal health, we'll do it. Well, the speaker said very succinctly, iron deficient mother will always give birth, almost always give birth to an iron deficient baby. So when we talk about replenishing iron in a mom, it can be cumbersome because of side effects or lack of education about iron infusions and some reticence on part of patients sometimes. But when we educate those patients and allow them to understand that their baby will have a lower likelihood of being born with iron deficiency, then that usually prompts buy-in. So iron replacement, avoidance of supplements that could increase bleeding. Again, turmeric, that's another one.
Yeah, so let's talk about some of the supplements.
Don't always equal good for you if you have a bleeding disorder.
Yeah, exactly. Also, things that are over the counter aren't always safe. So DHA is one of the supplements that is usually fine to take, but not always. So it's really important to talk to your doctor, your hematologist, if you have a bleeding disorder, about whether it's an okay thing for you to take. There are some patients, who noted, for example, chia seeds for very similar reasons because of omega, the presence of omega and its potential effect on platelet aggregation. So platelets being able to find each other and form a clot where it needs to go. To prevent bleeding, we had a patient who was adding chia seeds to her smoothies and noticed worsening bruising with that. And again, a lot of this there's some anecdotal reports, but I think that the take-home message is, if there's any question, especially if it's a fad, and if there's a new supplement kind of on the market that everybody's using, it's really important to have those conversations. Ashwagandha is another one where that's gained popularity recently for its health benefits. But really, people who have a tendency to bleed need to be careful with it.
A lot of times when you go to your physician, they ask for your medications they are taking. People don't always disclose all the vitamins and supplements that they are taking because it's kind of cumbersome and like, oh, you don't really want to know about all of these.
Yeah.
They're not that important, but in reality, they are.
Right. That's a really good point, Janey.
And then, going back to even the beginning of pregnancy, is there increased risk for miscarriage with patients that have a blood disorder?
There are certain medications, for example, which have a slight increased risk of bleeding for women who are taking medications for treatment of depression or anxieties, like serotonin reuptake inhibitors that are selective can have an impact on the way platelets form a clot. That being said, we always think about what's the risk versus benefit ratio. In the case of not treating depression well, that's a huge impact on mental health. It's also like the severity of the bleeding disorder, our willingness to accept the risk. Something like that, that's really important. So we might say, okay, well, we'll figure out the bleeding. And as long as we're prepared, for example, around the time of delivery, that patient, we may have to be more careful with things like tranexamic acid or having medications on standby, depending on the bleeding disorder. But if it's something that's, it may or may not be working, it's, a supplement that I'm taking kind of for my better health, then that's a very different conversation. So we try to individualize these recommendations because not every single bleeding disorder is created equal. The risks are different for each. We're ultimately treating the patient and not the disease.
I think that's such a great point. Basically, we should avoid the tendency to kind of make blanket statements. This is bad. This is good. It just depends on the person and in whom that particular ingredient is or isn't being used.
And what about other risks with pregnancy? Like, is there an increased risk with getting pregnant with somebody who has blood disorder or an increased risk of miscarriage with somebody who has a blood disorder?
It depends on the blood disorder. For most bleeding disorders don't carry an increased risk of miscarriage or of difficulty getting pregnant. And most of the risk is kind of related to the delivery itself. Now, there are exceptions to that rule, especially when you're missing certain clotting factors that are important for implantation that can then result in premature miscarriage, right? Like in the first trimester, but also some that make it difficult for someone to carry pregnancy to term. So I'll use the example of fibrinogen deficiencies, where a low fibrinogen is really important for the implantation piece, but then also to support the pregnancy throughout all its stages and for delivery. So in that particular situation, if the levels are under 100, then we would actually give fibrinogen replacement. But then also depending on the type of genetic variant, so the mutation, as we used to call it, some people actually also have a higher clotting risk. So sometimes we're giving fibrinogen at the same time as something like Lovenox, which is a medication to prevent abnormal blood clots from happening. So it gets more complicated and dicey. For the most part, I would say most bleeding disorders do not have an increase in miscarriage and difficulty achieving pregnancy, but there is a much higher risk of postpartum hemorrhage, both primary and secondary. So we need to have a great game plan for how to prevent that, or if there's any complications, how to treat it.
In the hospital, generally you have nurses and physicians around that are monitoring your bleeding. But when you go home and it's just you, like, how do you know what's normal? I know that you're supposed to be done with your postpartum bleeding by the time that you have your 6-week follow-up, but how do you know that your bleeding's a little bit heavier? Like, are there guidelines?
What we counsel our patients is, similar to what we see with like heavy menstrual bleeding. If you have gushing, flooding, if you have like passage of clots that are large, really we want to see the healing process. Most of our patients with bleeding disorders will go home on tranexamic acid to reduce the risk of premature clot breakdown. And what that translates to is about a 50% reduction in bleeding for most people, especially if we start to see, hey, I was healing pretty well and I was doing well. And then all of a sudden I'm changing my pad every hour, about a week postpartum. So as we talked about some of those markers of inflammation and inflammatory response and that help build clots. So that includes, factor VIII and von Willebrand factor. Those levels tend to go down about a week or two after delivery. So secondary postpartum hemorrhage in people with bleeding disorders happens around that time frame, which is why for most of my patients, I'll actually keep them on tranexamic acid for about 2 weeks after they deliver. There are some situations where I'll shorten it. Like if somebody totally, like the bleeding stops, like it's fine to stop it. But if it resumes, please let me know.
I have to ask because I'm sure that a lot of people are going to want to know. If you're breastfeeding with tranexamic acid, safe to?
Yes, it is. Tranexamic acid is safe to take during breastfeeding.
Okay, good to know.
I'm so glad you asked that question.
And you were talking earlier about pain relief. So you were saying like epidural, safe to get with a bleeding disorder.
I'm not going to commit to a complete answer on that because, I mean, it depends on the bleeding disorder and also if we can monitor the bleeding disorder. So if it's something like von Willebrand disease or hemophilia, where we have a reasonable turnaround time, we know what the levels are going into the delivery, then yes, I do think it's safe with close monitoring and experienced hands in close proximity or collaboration with the Hemophilia Treatment Center. But in situations where, for example, you have a bleeding disorder of unknown cause, depending on how severe it is, and we have no great ways of knowing whether what we're doing is working well, I have more hesitancy. Or in certain really rare bleeding disorders that are more severe, where I can't get a good level or replete someone because I don't have that factor product. Like factor V deficiency is one of those where, you need to give fresh frozen plasma, and some people can have really severe bleeding. And so because we don't have a product to give and we don't have great turnaround time, I would worry more, especially in an emergency setting, just because, it's not, if there are complications, hemorrhagic complications, it could be quite disastrous. So I really think it takes a shared decision-making approach with, when it's a mild bleeding disorder, I think there's a greater argument to be made versus benefit-wise. We want to alleviate the suffering and the pain related to the delivery versus some women actually, like who, if they're not candidates, end up needing candidates for what we call neuraxial, which is things like an epidural or spinal anesthetic. They end up needing general anesthesia to kind of get them through. And so that's kind of the big decision too, right? And of course there's so many benefits, right, to delivering while you're awake. But really we try to weigh the risks and the benefits for the mother and the baby.
What about like induction of labor? Many women end up having to be on like a Pitocin drip, and some people may or may not know that then that can sometimes increase your bleeding after delivery. Are inductions safe for people with blood disorders? Can you have Pitocin?
I think it's, again, a great question. We know that prolonged induction is associated with increased risk for postpartum hemorrhage. And I think that at the end of the day, just the consistent theme with bleeding disorder and pregnancy is that each person's care has to be individualized. So we shouldn't say induction is a good idea or a bad idea. We should say, what are the risks of inducing? What are the risks of not inducing? And then come to a collaborative.
So shared decision making.
Shared decision making. Exactly.
Empowering the patient.
Exactly. One thing that we haven't touched on, but I'll just mention, is depending on the maternal bleeding disorder, it may potentially affect their baby. And so one of the things that baby boys in the United States very often have performed within the first 24 to 48 hours of life is circumcision. So I think that just a mom understanding her bleeding disorder in the context of how it may affect their child. Dr. Lewandowska touched on always including guidelines for the obstetrician when an instrumented delivery should not be performed. And I can't stress how important it is that that conversation and that plan be had and documented well before due date, because we don't know when people are going to go into labor. And it may not be time for them to be in labor, but as we know, Mother Nature doesn't ask us. And it always seems to be about 3 a.m. when our most complicated patients go into labor. So having that plan on the chart, a copy goes to the patient.
Yeah, so that's actually a really important point. So again, the patient is the center of what we do. So all of our written instructions go to the doctors that are performing the delivery, and as well as the nursing staff that's on the floor, and the patient first and foremost, so that if all fails and the fax machine breaks and the electronic medical record crashes,
goes
the
down.
Like, I have the paper version
Exactly.
in my bag, and I would actually encourage patients who do have that to print it and carry it with you just in case.
Yeah. It's like people think about like the delivery bag, the overnight hospital bag. Forget your flip-flops and your chapstick. Bring those can be door dashed.
They can.
Bring your delivery plan, because at 3 a.m, you don't know which partner in that group of who knows how many is going to end up doing the delivery, or even if the doctor may not even make it there. So I just know how much more comfortable I feel when I'm able to look at that chart and see that plan on that chart. It just makes us all feel so much more comfortable. I'll just throw one more other note out there about neuraxial anesthesia. We talk about epidural and about spinal and, what's the difference and which one is appropriate for what situation. There are pros and cons to both, but I just want to, just as a plug for our anesthesiologist, let patients know that the spinal anesthetic needle is very thin. It's designed to puncture the dura, or the tissue that wraps the spinal cord and contains the cerebrospinal fluid. The epidural needle is relatively large. It's not designed to puncture the dura. However, it is not uncommon that it does. It's a difficult procedure, and it can't be precisely known where that needle is. So from a bleeding perspective, spinal anesthesia is almost universally preferred by our anesthesia colleagues to epidural when appropriate, because the needle is so much smaller, so lower risk of injury to blood vessels and bleeding. Also, a spinal anesthetic does not have a catheter that's then placed and then has to be subsequently removed. So we were talking about immediate hemostasis, delayed hemostasis. Just because someone's not bleeding at the time of their delivery doesn't mean that, they couldn't start bleeding later. And if that catheter is removed without having that knowledge.
Well, and I think that's an important piece that we worry about, is that usually people remember to give factor product for the placement, but they don't always think about, if it's been X amount of hours, depending on the factor product that's used, that those levels might not be high enough.
Exactly.
So then we worry about hematoma. That's a good point. And going back to just the shared decision making in terms of medications, a common theme is, as women kind of delayed childbearing, and everyone tends to be a little bit older during delivery, or most people tend to be a little older during
We're trending.
pregnancy
The
and
trend
delivery.
is that way.
Yeah. Exactly. What we're seeing is, sometimes there are complications, or there are higher risk pregnancies, and the need for aspirin, for example, for prevention of what we call, and I hate this term, geriatric pregnancy for ages 35 and over. And so
We like to call it advanced maternal age.
okay, I like that.
Yeah.
Yeah. I mean, I
have this image in my brain when I see geriatric pregnancy. In my brain, I think of like this woman who's pregnant with like a walker, it's like,
right. But I will say that, aspirin, like especially for women who have had complications in their pregnancies in the past, and I just want to also throw it out there that, again, there has to be a shared decision-making approach. So it's never just an automatic no. Yes, for most women, who have a bleeding disorder, that is something we try not to use, but there are certain situations where it's okay. So it's important to have that conversation about the risks versus benefits.
And that collaborative discussion between the obstetrician and the hematologist is so important. So very important.
Well, as a mom, as an ex-labor and delivery nurse, I appreciate the care that you guys put in, the time that you take into making these plans for our moms so that they can have healthy deliveries with good outcomes.